Okay, welcome to Simply Psych EDU, the 5-part lecture series on ADHD. We are annihilating stigma today. This is part 3. Okay, so today we're going to be talking about the diagnosis of ADHD, specifically in adults. So what are common signs and symptoms of ADHD in adults? We're going to attempt to answer that question today. Unfortunately, as always, I don't have any disclosures. I don't receive any money for doing these talks. Medical legal disclosures, you can read these on your own. I've already gone over these in previous lectures. So you've seen this before, just some diagrams and illustrations, although in this particular lecture there are less diagrams than previous lectures. This is me. So these are the learning objectives. I'm not going to read them to you. I show this every single time, but you can read them on your own. So probably one of the most important things that we'll talk about today, or the most important thing you should take away from this particular lecture, is this slide. And basically, what I want you to know is that ADHD is a clinical diagnosis. We do not have a lab test. We don't have a neuropsychological test that's good enough to diagnose ADHD by itself. So when we say it's a clinical diagnosis, we're really meaning we take the information we get from the diagnostic interview, what we observe in the room, what collateral information is saying, and if needed, we may order neuropsychological testing, but it's absolutely not necessary. And neuroimaging we will talk about in a little bit, but again, that's not necessary at all. So it really comes down to a clinical diagnosis, and there are good studies that show that neuropsychological testing is very inconsistent, and a thorough clinical assessment is better at identifying patients who have attention deficit hyperactivity disorder than any sort of neuropsychological test or lab test or neuroimaging test. So to start, the very first visit, when the patient comes in, you may or may not know whether the patient has a history of ADHD or why they're even coming in to see you to begin with. But if you sort of suspect there's an ADHD diagnosis, or if they mention that they're coming in because they want an ADHD evaluation, the first thing you want to do is kind of get a better idea of what the patient's motive is and what are their intentions for presenting. And I don't mean that in a way, it's often unfortunate because patients will report that they go see their doctor and they're very worried about being labeled as a drug seeker, or maybe they're worried that the physician's going to think that all they want is a stimulant, and that's totally not true at all. We shouldn't be making these assumptions at all. I think that's poor care, and that's for another time. But it's important to understand where the dysfunction is and where the distress is. And that's, I think that's sort of what you should be identifying very early on. So are they coming in? Why are they coming in now? Is it because they went to a bunch of other psychiatrists or providers and they told them that they don't have it and they still feel like they have an underlying ADHD diagnosis? Is it because they heard about it and they're wondering, wow, I really identify with this, I'm kind of interested in knowing, do I have this? Is it because all they do, maybe all they really want is a stimulant? They're just sure they may be drug seeking because of course people are people and humans are humans, and they do things, and I don't think that anybody can deny the fact that there are people out there that do that just show up to your office looking for controlled substances so they can either abuse or sell. But I don't take that as the norm. I don't think that that's very common. I think that being another human being who has a brain, my job is not to be a lie detector, but to really understand patients' distress and to help them in any way that I can based on what they're presenting with. So that's the first thing. Second thing is, using reflective listening, working with the patient to identify what the target symptoms are. This is important because many times patients who have ADHD, not all, but many times when they come in, because of the nature of the way they think, they may give you a whole bunch of symptoms and things going on with them, and it's sort of, you're kind of like, oh man, I have to, this is kind of all over the place. How do I sort of keep this, contained? And so what you really want to do is work with the patient to prioritize which symptoms or problems do they want to address first. So in the initial evaluation, it starts with observing the patient in the office. And some common observations you'll find, again, this is not for everybody, so everybody doesn't present this way, nor does everybody who has an ADHD diagnosis present this way, but some common observations. The patient will be jittery, difficulty with sitting still. Their thoughts will jump quickly from one subject to another. This is different than the flight of ideas that you see in bipolar mania. Many things remind them of something else, and so they have this sort of continuous thought stream that's kind of all over the place, but these thoughts are very rational, and you can understand the relationship between the thoughts. Sometimes it comes across like they have pressured speech, but it's really just a rapid speech sometimes. A difficulty with being on time. Sometimes they're late. But again, this is not, these are just common observations. This is not, every patient who has ADHD is going to present slightly differently, obviously, but these are just some common observations. Disorganized belongings, right? So you ask them, maybe you're discussing payment or whatever it is, or they're looking for their prior, documents from other psychiatrists, and they're opening up their bag, and it's just, there's no organization whatsoever. Everything's kind of just scattered. This is a common thing. Quick temper, low tolerance for frustration. This can affect the initial encounter, and it's important that you kind of keep your own, as the provider, sort of keep your own transference under control. And what I mean by that is just because somebody is coming in, upset and frustrated doesn't mean it has anything to do with you as the provider. Maybe they're just, they're having a difficult day, or they have had bad experiences in the past with providers. So it's important to sort of remember that, especially when it comes to patients who have or potentially have an underlying diagnosis of ADHD, because many times you'll find that these patients, they really have been, kind of through the ringer, right? They've been to other providers and they've been told various things, and maybe they're discouraged, they're frustrated. So it's just important to remember that. So with all that being said, I think this point is probably the second most important thing you should know. When we say attention deficit hyperactivity disorder, those common findings that you may observe in the waiting room or at the initial visit may not be what you see. And people say, well, how is that possible? Well, if you think about it for 5 seconds, okay, and you actually just think about this critically rather than jump to, some conclusion that's not based on any sort of a critical thought, think about this for a second. If a patient is coming to you and they're an adult and they've had attention problems for a very long time, or maybe they have, they've been having concentration problems for a very long time, they're disorganized. What you're going to find is that they may look like they're functioning okay. On the outside, they may have things together, but you have to ask yourself, what has gone into that? I mean, just because somebody isn't jumping, off the walls and doesn't have their stuff all disorganized doesn't mean that they've spent an enormous amount of time and energy presenting the way that they do. And so this is something really important, especially we don't want to just make judgments too quickly just because somebody doesn't have the quote typical ADHD symptoms doesn't mean that they're not really suffering and they haven't gone through significant distress. Now, it kills me when I hear people say, well, my provider told me that I'm smart and I have a job and therefore I don't have the diagnosis. None of those things are at all part of the diagnosis, and that is a terrible way of assessing somebody, period. I mean, that's based on bias, personal bias, that there's no clinical judgment that's going into that at all. I think that that's a really poor way of assessing somebody, is by quickly saying, well, they've got their life together, as if you know anything about that person's life in the initial visit when you're first meeting them. So I think that that's important to know. So some things you want to sort of identify and characterize in the first visit, the time course of the symptoms. How long has this, these symptoms been going on? You want to evaluate the level of impulsivity, disorganization, distractibility, and hyperactivity. You want to assess the degree of impairment and dysfunction. And by that, I don't mean you do that by just making it up yourself as a provider, saying, well, this person looks like they're sort of put together and they have a job and they put, clothes on that are nice, and so therefore they don't have ADHD. That doesn't mean absolutely anything. The patient will tell you their distress. You don't get to determine whether a patient is suffering. That's not the provider's role, in my opinion. I think I'm not somebody who's going to sit there and say, well, you're not really having an issue, as if I have any authority or I mean, to me, it's just so narcissistic to think that you really can understand somebody and know their level of dysfunction in a very short period of time at the initial visit. So really listening to the patient's, complaints and what's going on with them can help you understand their degree of impairment. And then it's important, the collateral information is important. I typically try to get collateral information if I can, especially when it comes to sort of the educational, occupational history, asking people, with the patient's consent, and if they don't want to consent, that's, obviously you don't do it, but if they're willing to let you speak with other people, sort of gives you not because you're trying to investigate in a way that's like, well, I'm suspicious, so I'm going to go talk to all these people to see if this person's a drug seeker or not. That's not the case at all. The idea is that, a patient, we all have biases and we all have our own views of ourselves, and sometimes they can be different than the way other people view you. And so I think it's important to speak to other people about, what are you like? What are you like when you're not sitting in the office and you're not anxious about, whatever it is that you're anxious about. And there are a number of things that can really affect a person's presentation in a psychiatrist's office, right? It's a snapshot of their life. It's not, it doesn't mean that the way they're presenting in the office really is how they're functioning in the real world. And so that's exactly why collaterals information can be very important and very informative. So obtain a comprehensive history. This should happen no matter what. You want to rule out, when people say they have issues with concentration, or they're feeling irritable, or they just can't focus, that's a very general symptom, right? I mean, it's a very non-specific symptom, and you want to rule out medical conditions and medications that really can cause people to present that way. And some examples, so the anticholinergic medicines like cogentin or benztropine, the antihistamines like Benadryl, or medications that have antihistaminic properties, for example, Paxil or paroxetine, some others, mirtazapine. There are many of the antipsychotics, many of the mood stabilizing antiepileptics, for example, Depakote and lithium. These are all associated with sort of inattention problems. Beta blockers, notorious for causing, inattention problems and concentration issues. And many of the antipsychotics, the atypical antipsychotics particularly, that have a lot of anticholinergic and histamine properties, really can take a toll on somebody's ability to focus and concentrate. The illicit use of drugs, right, cocaine and methamphetamine, are not going to help somebody focus and concentrate in the long term. Caffeine, anemia, right, B12 deficiency, thyroid disease, Lyme disease, many electrolyte disturbances like hyponatremia can cause, attention and concentration issues. And then the parasomnias. This can't be highlighted enough, but obstructive sleep apnea or sleep apnea of any kind, really any sort of an insomnia that's causing somebody, or preventing somebody from being able to sleep, is going to make them irritable and not able to focus the next day. I mean, this, everybody knows this. When you don't sleep the next day, you're just not as cognitively there as than if you hadn't gotten sleep. So it's important that you rule out all those things, because sometimes, and I've seen this, that somebody who really looks clinically like they potentially have an attention deficit disorder are really just really have severe obstructive sleep apnea, and once they get that treated, they do just fine. So the psychosocial history is important, right? So substance abuse in the past, numerous, job changes. Many times you'll find that patients who have a history of attention deficit hyperactivity disorder have changed jobs numerous times. Not always, right? Some people are able to maintain their, one job throughout their entire life. But these are just some common things you might see. School failure, how did they do in school? And not just, what were your grades? But let's say somebody says, well, I got like a 4.0 GPA. I think most providers will say, oh, well, that just means, you did really well, and therefore you probably don't have the diagnosis. That's not true at all. When somebody tells me they have a 4.0, I ask, well, what was it like to get that 4.0? Were you stuck in a library or in your room for the majority of the weekends reading the same page over and over and over again to get the grades that you got? I mean, those are the kinds of things you want to dive into. Did they get many traffic tickets? Are there marital problems? And then in terms of psychiatric history, you want to make sure you discuss any comorbidities, especially the mental disorders with overlapping symptoms. And then the family history is important. ADHD is definitely has a what's the word I'm thinking of? A genetic component, and so it can be inherited. Not by classic Mendelian inheritance patterns, but it definitely runs in families. So any family history of ADHD would be important, and then childhood history. So when it comes to your initial diagnosis, I typically like to use the ADHD scales and rating systems. There's a bunch of them. I think it's just helpful to better understand kind of what's going on. They usually, many of the rating scales, they'll have sort of they'll have two separate parts for the sort of inattention type issues and then the impulsive hyperactivity type issues, and it sort of gives you a snapshot of, okay, if they do, it's not going to make the diagnosis, but if they do have some, ADHD symptoms, like what seems to be the issue primarily? Is it both inattention and impulsivity and hyperactivity, or is it more they're inattentive than hyperactive? And so I like to use that in that sense. And it's all, and so what I mean by that is it's really helpful for differentiating the subtypes. And there are 3 subtypes of ADHD. There's the inattentive subtype, there's the hyperactive, impulsive subtype, and then there's the combined type. So just a quick note on imaging studies. I think the future is going to be in neuroimaging, but for what we have now in terms of data, it's not recommended. I don't think there's any, there's really no imaging study that's going to, aid in your diagnosis. It's expensive. Neuroimaging studies for psychiatric disorders are really limited to research settings, and it's unlikely that one, that any insurance company is going to pay for a patient's scan for a psychiatric diagnosis currently, but I do think that in the future this may become important. These are just some of the rating scales that you can use for adult ADHD. I really like the first 2. I think that those are really helpful. I don't use them as a diagnosis. I use them to sort of help me focus the the diagnostic interview a little bit. The Wender Utah rating scale. It's an interesting scale. I put it on my website because I think it sort of helps. It can be very hard for patients to remember their childhood and how they were, especially if they're much older. And so I do think that this kind of helps patients remember a little bit about their childhood and were they experiencing these different symptoms. Can they remember if they were experiencing these different symptoms? Because that can also really help in the diagnosis. So common lifetime comorbid conditions. So ADHD rarely stands by itself. So you can see here that it's broken down by men and women. This is taken from a paper by Biederman. But it's interesting because when it comes to ADHD, anxiety and depression are by far the most comorbid conditions. And that's not surprising to me at all, right? I mean, you grow up as somebody who has attention deficit hyperactive disorder, you're having problems in school, you become so either anxious or depressed about having to spend so much time and energy doing something like reading or studying when other people they can get it much quicker. Perhaps your self-esteem has sort of dropped. You're just like, forget it, I'm going to start using drugs, I'm going to start doing other things, whatever it may be. It's not surprising to me that there's a comorbid anxiety and depression, often with ADHD. Many times, patients will say, well, I'm so anxious when it comes to tests because I have to sit there for so long, and I have a hard time really focusing and sitting there, and it makes me really anxious. And that, I understand that, it makes sense, right? I mean, if If it's difficult for you to sit still and somebody's requiring you to sit still, I mean, duh, I mean, you're going to get anxious about it, right? And if you can't perform, you're going to get depressed and you're going to feel low. So I don't think that this should be surprising. One of the hardest things to do is differentiate between attention deficit hyperactivity disorder and bipolar. And I think that many patients who have underlying attention deficit hyperactivity disorder get labeled or diagnosed with either bipolar 1 or bipolar 2, or sometimes even probably borderline personality disorder. Not to say that they can't all be comorbid together, but I think that it's important to know the differences between ADHD and bipolar disorder. And we're going to go through each one because I think this is really important. So when it comes to the signs and symptoms, when we say hyperactivity, in ADHD, if it's present, it's a constant thing. This is not something that happens in episodes or, for a couple days they're this way and then a couple other days they're not hyperactive. It's like if they're hyperactive, they're always going to be hyperactive, okay? In bipolar disorder, you really only see it during manic or hypomanic episodes, and they're episodic, right? It comes and goes. But it comes and goes in an episodic pattern. It's not, one day I'm this way, the next day I'm this way, or half the day I'm this way, the other half I'm this way. That's not how it works. So when it comes to mood swings, which is the next symptom, in ADHD, it's rapid and it's brief. So people who are saying, my mood is like going up and down. One day I'm this way, the next day I'm that way. In the morning I'm this way, in the afternoon I'm that way. That's much more likely to be ADHD or something else other than bipolar disorder. Bipolar disorder is defined as an episodic illness, and the mood swings are episodic. They're the ups and the downs. They are sustained. They last for days to weeks. It's not rapid and brief like you see in patients with ADHD. The difficulty with concentration isn't a constant problem with patients who have ADHD. In bipolar, usually the distractibility and the inability to focus really happens during manic or depressed episodes. So that's important to characterize. Is this something? Is your difficulty with concentration? Is it something that happens all the time, or is it? Sometimes I feel like I'm really. There are periods of time, weeks at a time where I'm fine. I can get it, and then there are other weeks where I'm not getting it. And so that's really going to help you differentiate the two. Euphoric moods, you don't see it in ADHD. Patients with ADHD are not euphoric. They're not walking around grandiose, making ridiculous delusional claims. That's only present in bipolar mania or psychotic disorders. And it's, again, episodic. It's only during those manic episodes. Delusions, again, not present in ADHD, but it may be present in mania. Chronic irritability, it's usually not present in ADHD, but in bipolar disorder, you'll often see it. Frequently losing items. This is common in ADHD, but it's not common in bipolar disorder. Hallucinations may occur in mania and bipolar, but it does not occur in ADHD. Sleep disturbances. Okay. Many patients with ADHD have chronic insomnia. Okay. They have chronic insomnia or they have hypersomnia. They either don't sleep enough or they sleep way too much. And in bipolar disorder, you really only get the insomnia during those hypomanic and manic phases. And so again, it's episodic. I keep using the word episodic, because I think people too quickly say, I have mood swings, therefore I have bipolar disorder. That doesn't mean anything. You have mood swings. People who don't have any diagnosis have mood swings, but they rapidly fluctuate from day to day. That's not bipolar disorder. That's typically not bipolar disorder. In terms of disorganization, it's a key and persistent feature in ADHD and bipolar disorder. It's not common unless manic. Same thing for distractibility. Same thing for grandiosity. For self-esteem, it's usually poor, right? The patients with ADHD usually have a low self-esteem, and that makes sense. That makes sense. I mean, when you're told your entire life, well, why don't you just figure it out? Can't you just sit there? Can't you just do this? Why aren't you doing that? They're just constantly being criticized. You just need to work harder. It's like, it's going to make anybody's self-esteem poor. And in bipolar mania, usually the self-esteem is high. It's inappropriately high, right? They're grandiose. They have inflated self-esteem, and that's episodic again. Racing thoughts, it's chronically present. People say, oh, I have racing thoughts. There's so many providers who jump to bipolar disorder when they hear racing thoughts. It's like, racing thought. When I hear racing thoughts, the first thing I think is anxiety and ADHD. Those are the two things I think of. Racing thoughts, these sort of chronic racing thoughts, very characteristic of attention deficit hyperactivity disorder. It's very characteristic of anxiety. And in bipolar, it can be present, but it's usually during mania, and it's really it's not just racing thoughts, it's sort of rapid flight of ideas, jumping from idea to idea very quickly, only during a manic episode. Impulsivity, it's a common feature in ADHD. It's not common in bipolar unless you're manic. And then, the high-risk behaviors are also very common in ADHD. But the reason it may occur, the high-risk behaviors, but the reason generally prevails. But during bipolar mania, you'll have high-risk behaviors, but they're typically much more severe and life-threatening. So in patients with ADHD, they may have impulsive or high-risk type behaviors, but it's but their sense of understanding and reasoning always usually prevents them from doing anything absolutely ridiculous, right? But somebody with bipolar mania may do something very extreme and life-threatening. Couple notes on ADHD and substance use. Untreated adolescents with ADHD are at high risk for drug and alcohol abuse. A large study at Mass General found that stimulant treatment was protective against the later development of substance abuse. Individuals with unmedicated ADHD are at 3 to 4 times the risk for developing substance use disorders as those who are medicated. And adolescents with both ADHD and substance use disorders have a higher risk of suicide. So those are just a few of the studies. There's many, but I think that those are probably some of the best. But it's very clear that untreated ADHD is a very high risk for drug and alcohol use. And I think that that's probably the biggest argument for why we should be really hypervigilant about the diagnosis and not really stigmatize it in any way, because that's not helping our patients at all. So adults with untreated ADHD are at twice the risk of developing a substance use disorder compared to adults without ADHD. Research has shown that in patients with past substance use disorders, stimulants do not prompt the patient to revert to past behaviors. So whenever I'm assessing a patient and I've come to the conclusion that they definitely have a diagnosis of ADHD, I'm not going to use their history of methamphetamine use disorder against them. I mean, it sort of makes sense that they would use a stimulant. And so, I don't think that by prescribing somebody a stimulant, they're going to all of a sudden say, oh my God, this medicine is now making me want to use street methamphetamine. Now I'm going to go buy illicit methamphetamine and start shooting up my veins because I'm taking Concerta. I think that's absolutely ridiculous to think that. Patients, that's like, where does that idea even come from? People just make shit up. They just think that, oh, if I give them this, it's going to make them want to go use drugs. There is no data to suggest that at all. In fact, there's more data to suggest the opposite. So I don't understand that line of reasoning at all. Stimulant-treated patients with ADHD, when properly dosed, rarely require escalating doses over time. and rarely fit the description of a substance abuser. That's a really important thing to mention. I think that, you know, patients who are adequately dosed rarely, if they're adequately dosed, require higher doses of stimulants. If you're finding that somebody is requiring higher and higher and higher doses of stimulants, then maybe you should start thinking about maybe this is not the right diagnosis, right? But typically, you know, if you're dosing it adequately, and I don't mean, when I say adequately, I mean that you're really, you know, providing them with medication that, if it's a stimulant, for example, that really is at a dose that's therapeutic, then you really shouldn't have to go up on the dose over time. And definitely, you know, I've seen this. I think Dr. Young in his book, Joel Young, he talks about this. He's been doing this much longer than I have, much longer, much more experience, many more patients, and he will say the same thing, that rarely do you have to go up, you know, over time. So a little bit about stimulant misuse and diversion, because this is a hot topic, particularly when it comes to college campuses, and people love to throw this, you know, whenever I'm arguing for or advocating for, you know, the proper diagnosis and treatment of ADHD, the first thing people say is, well, that stuff is abused all the time. It's abused all the time in colleges, and this is a problem, and it's like, okay. I mean, I understand. We'll talk about this more in the last lecture on the stigma and misconceptions. But, you know, when you look at the data in terms of the dangers of prescribed controlled stimulants, it's nowhere near what the dangers or the risks associated with the use of prescription stimulants, or the misuse of prescription stimulants. The data indicates that we really are overly fearful, I think. This is not street methamphetamine we're talking about. People aren't coming to emergency rooms in high numbers because they're, you know, taking their controlled medications. So a recent meta-analysis and systematic review has basically shown that prescription stimulants, the misuse of prescription stimulants, and the availability of prescription stimulants has risen among college students without the disorder. And recently, the prevalence that has been reported, the prevalence rate that has been reported for stimulant misuse was somewhere between 3 and 23%. So yeah, that's pretty high, and that is concerning. And misuse should be distinguished from substance use disorders. Okay, there's a difference, and this is important. So, and let me explain what I mean by this. When somebody uses a prescription stimulant, let's say that Joe gets, you know, an Adderall or something from his friend because he has to finish a paper, and he feels that if he takes this prescription stimulant, that he will do better, which probably he's not going to do much better, but that's for another time. But basically, he's therefore misusing the medication. Okay, that's misuse. Okay, he's not using it for a medical, you know, he's not using a prescription that's his. He's not using it for, you know, for the indication that it's, you know, for the proper medical indication. So that this is really misuse, right? People misuse drugs all the time, okay? That's different than a substance use disorder where the patient or the person is now, as a result of this particular drug, is, you know, experiencing dysfunction in their life because they're spending their time trying to find ways to obtain this drug. They are forgetting about important aspects of their life because of this drug, and this is a pattern that is becoming, you know, that's really affecting this person's functioning. That's very different than misuse. So misuse was found to be inversely correlated with academic performance. So, next time Joe thinks that, well, maybe if I get a stimulant from my friend, I'll do better. Well, the data indicates no, right? There's a negative, there's an inverse correlation between how well somebody does academically and their misuse of stimulants. So I think that this is a very powerful message to college students, that using a prescription stimulant may get the work done, but it doesn't make your work better. And lastly, the risk for misuse was highest among Caucasians, males, individuals in the fraternity sorority life, and low GPA. Those are all risks for misuse of prescription stimulants. Not to mention that I'm sure there are many individuals who have a low GPA, and they have a low GPA because they have an underlying diagnosis of ADHD, and they get benefit from misusing stimulants. So I think that those are kind of the questions we should be asking. We should be thinking about that, right? I mean, why is this happening? Are the people who are misusing stimulants, why are they misusing them? Why do people use methamphetamine on the street? Why do they do that? Some people use it because it helps them. As crazy as that sounds, I've met many patients who say that when they use street methamphetamine, although it's damaging their brain, they're better able to focus and get things done. Because without it, they are a mess. Now, that doesn't mean you have the diagnosis of ADHD. It doesn't mean anything. But what I'm saying is that we shouldn't just automatically think that, oh, this person is misusing. There's no way that this person could have an underlying diagnosis. In fact, if somebody's misusing a stimulant, I'm going to start thinking, why are they doing that? What is the reasoning behind that? What's driving this person to do that? Right? Is it an underlying diagnosis? If I can treat it, maybe they won't misuse it. And that's the end of part 3. Parts 4 and 5 are upcoming, and they will be posted at some point in the next few weeks.